Hello, thank you for joining this AI Insights webinar brought to you by AI Med in partnership with Applied Radiology, and major thanks to Gerbe who have kindly sponsored the session. My name's Alexis May, Director of Content at AI Med. I'm pleased to be joined by an excellent panel today as we discuss AI economics. Just a quick note to mention that Judy Gichoya of Emory University has been called into clinic today, so sadly cannot join us, but we have not one but two additional speakers joining us today. So in addition to Sonia Gupta, Senior Medical Director at RAD AI, and Melissa Chen, Clinical Neuroradiologist at MD Anderson, we've got Ari Goldberg, Director of Thoracic and Abdominal Imaging at Loyola University Health System, and Ashim Bhatia, Assistant Professor of Pediatric Radiology at the Children's Hospital of Philadelphia. Thanks all of you for being here. This session is going to take a sort of discussion format. We would love for you to get involved, so please do post any questions, comments in the appropriate tab on your control panel, and we'll weave as many as we can into the conversation. That's more than enough from me. Let's get started. Over to you, Dr. Gupta.
Thank you so much, Alexis. Thank you again to our sponsors. Thank you to AI Med, Gerbe, and Applied Radiology, and to our wonderful panelists for being here today. Thank you for everyone else who had made time to listen in today on AI and economics on this Tuesday afternoon or morning, depending on where you're living, your time zone. We're just going to jump right into it and start with just some basic questions, just to get an idea. You know, we have 3 large academic medical centers represented here among our panelists. So just to start off, Dr. Chen, could you talk to us about any artificial intelligence that's being used in your practice currently? And if it is being used, what type of AI is it? Is it for triaging cases, actual diagnosis, image interpretation, or is it workflow focused?
Yeah, so we have a couple of algorithms that we've been using in various sections. Most of them are around lesion detection, like a lung nodule detection algorithm. We also have one around, breast lesion sort of algorithms. We are exploring other types of AI, including sort of the dictation software algorithms that's slotted for the future. And then there are other areas of AI that parts of our operations are looking at in terms of utilizing for operational flow.
Great. And how about you, Dr. Bhatia?
Yes, thank you. So we're currently in the process of reviewing multiple softwares as well. Some are for workflow, some are for actual image analysis. And one interesting one that actually we're looking into is for the actual dictation report for optimizing the impression. But the software that I probably have the most experience with is Patient Synopsis, which is from Gerbe, teamed up with IBM Watson, which also looks at electronic medical records. So that's the other product that seems very interesting and appealing to a lot of radiologists.
Great, so more on the workflow side. How about you, Dr. Goldberg?
Yeah, we have some we have some algorithms in play in terms of breast lesions, some kind of translational research and clinical research that's being used to kind of further understanding with prostate. We also, sorry. We also, same thing, as we are kind of in the process of looking at, operational type software like Synopsis. You know, there's great things and bad things about being part of my Loyola is owned by Trinity, which is like 100 hospitals. So there's a lot of beautiful scale to that, and potentially what we decide. But there's also a lot of perseveration that goes on in terms of which is the best direction to go in, and what's the best within those directions. What's the best product to use?
Well, that actually ties into our next question nicely. What is the process for deciding then which program you might use? You know, all 3 of you have mentioned programs that do all 3 things, like workflow, triage, image analysis. How do you decide which program you're going to use? And then also, once you decide, who's using it? Like, do you have super users or volunteers, or does everyone have to use it, whether they want to or not? Like our computer upgrades.
Yeah, I think it's kind of on a case by case, just depending on the type of algorithm that's being utilized. you know, there are some super users potentially that are tapped to try out a product and then do an initial assessment and then decide whether or not we should more fully adopt it. And then they're just sort of pilot projects looking at specific, using it in a specific use case scenario, and then broader adoption across different sections. We're a little bit complex because we're pretty segmented in different departments, and we kind of operate independently from each other. And so in trying to, you know, look at AI algorithms, it's starting to become a challenge to try to integrate across the whole operations of diagnostic imaging and trying to account for everyone's needs while not overloading our IT team.
Yeah, I know two of you mentioned, you know, breast imaging algorithms. So then obviously at least that would only be used by the mammographers in that case. So it would be more obvious. But for some of the workflow and triage, it's interesting. I think a lot of centers are just doing the model of having volunteers first that can try it out and then kind of report back to everyone else. What about you, Dr. Bhatia? How's your place doing it?
Yeah, I've had experience at multiple or a few institutions, and to me, it's been similar where you have a super core, a group focused on AI, and a lot of it, you have radiologists, you have the PAC specialists, you have the IT experts, everyone working together. You kind of give a pitch to the group. So you say, hey, this is a software that I'm interested in, this is why. And then you get a few questions, mostly from IT teams saying, how do you implement it, or how can we implement it, and what kind of, it's more complex than my understanding usually, but that's how the process has started. And then there's a lot of work done beyond that in deciding, is that something that can be easily implemented? So I think that's the approach we're taking, is finding a software that can be easily implemented with goals that are relatively simple for the software, and something that's, I know we're going to talk about probably a little farther down the road, is the commitment to that software. So those are all things to consider when the core group is first evaluating software. So it's very small, I think a small percentage of that institution that's deciding it, but a lot of it comes from people that just have that interest, and they're taking the time out to discuss AI implementation.
Right. And then Dr. Goldberg, is it similar at Loyola?
Yeah, I mean, aside from like there's this sort of structure above, which is Trinity I was mentioning, but even in-house, it's funny, they both mentioned really good points, and I think what is that there is no, it's in our case, I actually don't think that the bottleneck, the rate limiting step is the IT integration. Like, you know, we have the, it's where the will is, and we have different people from different sections that are into AI. You might have one breast imager, one chest imager, and there's not a cohesive thing. And it's actually, it's funny because I've been thinking recently that wouldn't it be great if we had, you know, everybody has a vice chair in these academics, everybody has a vice chair of clinical operation, everybody has a vice chair of research. Well, maybe we're getting to the point now where we need in these departments like a vice chair of AI, you know, to really kind of tie it all together, because you have people that want to use it at the sectional levels, but, you know, the chairman may be too removed, you know, to be too busy to be able to sort of synthesize that. But then if you go a level above the chairman to some kind of, you know, kind of more corporate structure board, you get lost in the time frame. So I think my experience is very, very similar, and I think the sort of the good news is the same as the bad news, right? That the rate limit step is sort of the organization around the people. So, you know.
Yeah, you're absolutely right. I mean, it's like publishing an academic paper. There's lots of layers and there's revisions and edits, and, you know, it kind of goes back and forth. And I think that is something that even if you're in private practice, there's going to be layers of people to get approvals. And that kind of ties in now to our next question. We were talking a lot, this is economics of AI. So let's get into that a little bit. Dr. Chen, do you know, is there a budget specifically for AI, like actually tagged for AI? And then, you know, the next question is it capital budgeting actually from the academic medical center as a whole, or is it just from the radiology department? Because that's something that we've come across, is questions about who's going to pay, whether it's going to be the hospital system at large because they believe that it benefits everyone, not just the radiology department, or if it's only the radiology department, that kind of divide there.
Yeah, I mean, it's a good point you bring up in terms of who's paying for this at your institution. We at MD Anderson, there's not necessarily a dedicated AI budget, but it sort of falls under software, which I suspect a lot of people are doing similarly, where there's a software budget. And you know, all of those requests go into that same bucket. In terms of, you know, MD Anderson, we have our operations that is kind of separate from the faculty side of things, and a lot of the budgeting kind of comes out of that operational budget for us. And in terms of, I think, you know, the issue with trying to see who pays for it within an academic medical center, I think, is a valid one. I think it's really important when a department is trying to look at AI algorithms to try to align with the current, especially when trying to find the money for it, right? Because there's really no business case right now to use it, because you don't get additional, you can't charge an extra CPT code. There's no additional practice expense that you get from that, aside from, you know, very select code. But we can talk about that later. So I think that if there are quality initiative projects where the institution is specifically looking for certain issues and aligning and being able to show that this AI algorithm can help to accomplish that, or that type of thing is what is needed if you're trying, if a department is trying to tap into a larger budget or to try to get that extra money for, you know, the needs, the IT infrastructure needs.
Yeah, absolutely. And I guess another part of it might just be that it's too early. It might be too early on in this phase of AI to actually have a line item in the budget that says AI, because you're right that it can fall under operations, software, you know, even IT actually, technically, right? Because we need IT support in order to deploy any of these AI solutions. So the money can be found in a different part of the budget for sure. How about you, Dr. Goldberg?
With us, there's three different levels, right? Unfortunately, I'm sorry, I had to. There's three different levels. So there's like a slush fund that the chairman has, which he says is 3%. I think it's a little more, but anyway, we won't get into that. So they can come from there. It can come from there. It could come from the usual budget cycle, which is things that are like under $100,000. So that a lot of this fits in very nicely, that, right? Because these are based on kind of contracts and licenses. That the problem is that so it doesn't really rise to the capital budget process, which is a good thing. However, the problem is that anything that goes outside of the department still gets stacked up against what other departments need. So the urologist, the cardiologist, so it all goes into one big bucket. So there's a definite defined process, and it's not a bad process, right, for things that are under 100,000. It doesn't require like this a lot of levels. However, it still gets thrown into sort of a multi-departmental bucket, and that's a little bit challenging.
Yeah, I mean, it's definitely a balancing act, because you're right, other departments are buying, you know, like their equivalent of a CT scanner might be a Da Vinci robot or, you know, something for the OR perhaps. How about you, Dr. Bhatia? Do you know how they're kind of doing it over there?
Yeah, some of the Ari, what he mentioned, it sounds like Ari has a fan back there that's not parking back there, but it reminds me that a similar approach, but the difference over here, I think it's more departmental, and I think that's with multiple softwares that I've experienced over the years, whether it's advanced imaging analysis, all these softwares are department driven. So for example, we had advanced imaging software that was cardiology owned, so I had to work with the cardiologist to get access to it. And with AI, it's similar. The radiology, currently our focus is implementing an AI focused software for our department, so it's going to be funded by our department. In the 100,000 range, I think that's similar to what Ari mentioned, is that's a good number to say, hey, this is kind of within our budget for this software. But and I think as AI advances, like we were hinting, there's going to be more multidisciplinary, more multi-department approach to these softwares. Currently, it feels like everyone's focused on what's best for them. But as these softwares advance, and you look at software that can appeal to multiple departments, you can start looking at more institutional approach to these softwares. And I think that works with, depending on how you look at it, like the workflow, that could help the ED, that could help triage or other departments. And so everyone eventually will, I think, look at it as a whole, but right now it is departmental driven.
Yeah, and then, you know, going back to what Dr. Chen said, you brought up the CPT codes and the reimbursement. I wanted to dive into that a little bit. You know, has there been any consideration or discussions in your departments respectively about possible reimbursement from insurance for using AI? Like, you know, we're aware of a few companies that have new technology add-on payments that they've been able to associate with usage of their product, so that it's a lot more appealing for the hospital system at large to use the technology. kind of something similar to what was achieved for CAD, now moving on to more of these other vendors. You know, Dr. Chen, I know you do a lot of work with reimbursement and insurance companies and CPT on behalf of the ACR. So what have your thoughts been on this? Have you seen any good models out there?
No, I mean, I think that the AMA is starting to look at how do we categorize different types of AI. Is it assistive versus, they have specific categories, right? Assistive, or is it autonomous? I think for the autonomous code, so for example, there was a diabetic retinopathy code that was a category 1 code that came through. It's not for radiology, but for ophthalmologists. That one was a practice expense only code, so there's no reimbursement for any for the physician work itself. And that seems to be one model in terms of trying to get forward a CPT code. The category 3 code for radiology that came forward, so that means that reimbursement's not guaranteed, but it is something that is the decision can be made at a local level by different carriers, and that's for the detection of vertebral fractures on pre-existing imaging that's in the system. And so that one also is somewhat of a, you know, a practice expense. I don't know that there's much physician work involved in that. And so I think that's sort of where some of the models for AI in the physician fee schedule is. In terms of, you know, is there a model for the assistive work that AI does with physician work? I don't know that there's an appetite to have any add-on codes for the work that we do. And I suspect in the future, it will just sort of become bundled into the work that we do as physicians. If it becomes typical, so the RUC will value things based on what typically happens, so greater than 50% of the population. So once an algorithm is out there, occurring greater than 50% of the time, and depending what that does for our work as physicians. Does it increase it as a radiologist? Does it decrease it? You know, that there are a lot of debate around that, but that's potentially ways that it could impact valuation in you know, a way to get valuation. So it's a very, I don't think it's a satisfying answer for those that are trying to look for actual direct payment from payers. And then there's the NTAP, which is the hospital payment for the stroke triage algorithm. And that one, of course, vendors are open to applying for those. I think the hugest hurdle is that there is a focus on ensuring that it improves patient outcomes. And I think that there was a recent code that was put forward and proposed by a vendor, and it was rejected primarily because the CMS didn't believe that it really improved overall patient outcomes. So I think that is one big hurdle for AI companies.
So in order to get the new technology out on payment, you know, for our listeners, they have to show that the patient outcome has changed, right?
Yeah, and while reducing overall costs theoretically.
Okay, so yeah, that does seem like a pretty high hurdle. And right now we've only got one example of that in stroke triage, because that is a question that comes up sometimes, is vendors wondering if they can apply the NTAP to their product to make it more appealing, because now, you know, maybe we can get reimbursed for using it. And, you know, Dr. Chen, this is a serious hurdle. So I think that would be a barrier of entry for a lot of, you know, the billing codes or reimbursement issues, and maybe, unfortunately, decrease the appeal, because then it's, you know, the ROI is, well, we still have to figure that out, I guess. Dr. Goldberg, what are your thoughts on this?
Well, I mean, I just think it's if an AI product is as good as you know, if it really is what it's supposed to be, then in a sense it doesn't matter whether it has that code. And I think we should kind of expect that there won't be this, you know, this code that we're going to make a lot of money off of, you know, to justify using the AI. It'll have to justify itself based on outcomes and productivity and all those other quality metrics that sort of are built into the fabric of, you know, our billing and our quality and avoiding lawsuits and all that kind of stuff. So I don't have a problem with that. I just think, you know, if it's stuff that's worth its salt, that'll come out in the wash, I think.
Yeah, Dr. Bhatti, I know you had mentioned before you had done some AI research. You know, I was wondering, in that regard, were you able to use the products for free, you know, as part of a research partnership, like from the perspective of an academic medical center?
Yeah, good point. And I think that's the way that a lot of individuals or institutions get experience with the AI software is through research collaborations. And that's the one that I'm currently working with Groupe with Patient Synopsis, is to get the access to it early, where you can get, I'm a research-minded person in general, so a lot of my work, whether it's brain tumors, I can easily adapt that mentality to AI software and say, hey, how are we going to approach it? What's the clinical question? How are we going to test it? So you have your hypothesis, and then you have your data, you analyze your data, and you produce reports or manuscripts, and I think that's the way I would approach it. And it provides, like you were saying, the ability to integrate the software into your institution. It gives you exposure to it that you probably wouldn't get in another way. So I think that's a good, and I've had other, I will say I have other AI softwares approach me and saying, hey, how can we use this software at your institution, whether it's for stroke imaging or other applications. And I think, I mean, a children's hospital, it is a more unique ground for using AI, because like things like stroke, while not as common as adult population, you could implement it, but you're probably not going to get the data that you want, that you would at an adult institution. So you do have ways to approach it. And so I do think that's a promising way for, and I encourage a lot of people to try that as a way to test out softwares in the future.
So then how do you decide, or at least can you elaborate on at what point you move from the free partnership that's research oriented to like a paid subscription? What happens at that point?
Yeah, and that's all built into the contract early on. So once that contract's provided to you, it's going to be analyzed at multiple levels. So initially the research focus, that's probably relatively easy to get approved, because you go through your normal process of getting any research approved. But then within that contract, it goes to another level of approval. So administrative within the department and institution have to approve the budget of whatever that is. So it could be subscription-based software. It could be on an annual basis. So that has to be looked at as, is it within the budget, and is it worth the investment from the institution? And to me, it's always been the question of, we have this many resources, this amount of people to work on AI software. Is it worth the time of this group to look into it? Even if there's a research built into it, that's still always a question. But it makes it easier. I will say it makes it easier to have that trial up front, even if the contract's built into it, because a lot of them are on a trial basis. So if you want to back out of the contract down the road, you can. You have that opportunity. But yeah, that's my experience with it.
How about you, Dr. Goldberg?
Well, I would say the contracts have a certainly like a mechanism by which something can move from research to a commercial to a center, but unfortunately it's not very well defined, like what makes, again, how that decision is made, though. That's not like built into the guide. It's not like the contract says, well, if it has this % sensitivity and specificity, we're gonna transition to buying it and using it clinically. So I think those same issues still come up. So again, it's not so hard to have it in the contract of how something can graduate into it, and to sort of grease the wheels for that process. But still, transitioning is still more difficult, because then somebody says, okay, well, what are we just going by our data? Is it the general literature? So that process is, at least in my institution, hasn't really been defined yet.
Right. Yeah, I mean that hurdle of going from the research partnership to the paid subscription isn't always clear, even if you have a contract, as to which way the decision's going to go. Dr. Chen, what's been your experience with this?
To be honest, I haven't had much experience in terms of the translation of research to the clinical practice. I was actually looking at the questions in the chat. There's some interesting questions that are being asked. If you don't mind, I can address one of them. There was
absolutely.
There was one question from someone who asked about whether or not we had heard about United Healthcare doing a longitudinal study of how the cost of AI is justified based on it enabling earlier detection, which reduces the eventual healthcare cost of the patient, and how does this help hospital C-suites to embrace AI, since payers may do preference of providers that have AI. And I think that, so I haven't heard about this particular longitudinal study, but it doesn't surprise me that payers are looking at potentially in a sort of a more risk-based model where, you know, a system or an insurer is accountable for the overall costs of their insurees or patients. I think that this is where AI makes sense, right? The long-term goal of AI would be to be able to triage patients, to be able to say that, you know, these patients are responding to therapy, these patients are not, these patients, or earlier detection of disease to save overall costs. And I think that it's this type of longitudinal study that will be needed when we start thinking about more of these risk-based payment models. And I think that's where the future is in terms of the value for AI. And I think that those are the interesting questions that I you know, think that we should go after. Obviously, there are a lot of steps to get there, and I know that we're still kind of in the infancy of AI.
Yeah, no, absolutely. I think earlier detection, you know, from a population health perspective would improve outcomes. And that is definitely an area that we should be able to hopefully get data from. You know, because this goes to the next one of these other questions that came up about how important it is to be able to explain what's inside the black box to drive adoption and reimbursement, as we were speaking about earlier. We don't know, I guess, right? We right now at this point, you know, and this is why we're really talking about it, and why I do think the economics piece is so important, because we're still trying to figure it out. This is all brand new. There's not already a CPT code or a defined pathway for reimbursement for these individual vendors to follow. So it's all just kind of on the fly.
I will say that for, you know, I think, I don't know that there is a need to understand inside the black box, you know, from the reimbursement perspective. I think it just needs to show in the data that for a particular payer's patient population, so whether it be for CMS or for whatever payer is interested in potentially reimbursing for that AI, that there is shown improved outcomes. And I think that's probably, you know, the hardest one.
But what if, let me ask you, Melissa, what if that study is tied to a particular product, a particular AI? So that's what I'm wondering. So is Aetna or, you know, Blue Cross Blue, are they going to say, oh, well, the AI worked, but what about Siemens?
What
AI?
about some other AI algorithm? Yeah, I think that's a great question. I think that those are things that I think is still question mark. And I think payers are asking that question. CMS is asking, how do we consider other software algorithms that come forward that may have a similar mechanism, or say that they have a similar mechanism? How do we triage that? Is that different? Is that a new software? So I think those are all questions that you know, they're looking to the AI world. And I know ACR has efforts towards trying to find ways that they can standardize these processes, figure out how do you know, what are the parameters? How do people assess these? All of that.
Yeah, one thing I was going to say, I saw an email from ACR that was looking into feedback from radiologists and the community of how to get CPT codes approved for AI, or what the focus should be, I think. But one thing, as far as a research focus, I look into advanced imaging a lot, and one of the hurdles with advanced imaging is the time consumption for radiologists to use those tools in the clinical workflow, which is reasonable, because we have a high volume. You're trying to implement, like, how do I quantify all these DTI indices and contrast perfusion variables into my clinical report? And I think that would be one area that could get approval for reimbursement, is finding a way to make that simplified process and getting those advanced tools into our clinical workflow, which everyone's trying to do. That's the whole point of translational research. How do we get these tools into an AI? Could be that bridge to help us implement it, but at the same time help looking to get reimbursement for a lot of those tools that are not being used currently.
Yeah, absolutely. I think, you know, it's also thinking about what Dr. Goldberg said, that maybe it's not really about whether we're getting paid to use it, but just, or making money off of it, really, because that's not really what anyone's going to be doing if you're using it clinically. But just the fact that at some point it'll just be that we all use it, and it's not really the biggest factor. Maybe right now, because it's a little bit newer, we're thinking more about the potential reimbursement and being able to justify the upfront cost, because somebody has to pay for it initially, just like you have to pay for a CT scanner or an ultrasound machine. you know, a department or a hospital has to take that cost on at the beginning. And, you know, whereas with an ultrasound machine or a CT scanner, we know that we're going to be able to see a certain number of patients and justify the cost. We're just not able to duplicate that right now with many of these AI algorithms. And that's kind of, I guess you could say, the black box, like the earlier question, still trying to figure that out. And it is kind of a free-for-all right now. I mean, the ACR is doing a really great job of keeping track of FDA clearances for various products that are out there at various vendors. But I mean, if you really look at it, a lot of them are doing the same thing. And, you know, there's like broad categories where everyone is trying to identify pneumonia or breast cancer detection, and they're all trying to get the same FDA clearance. And it's just, yeah, I mean, in some ways it is a free-for-all. They're all doing the same thing. And so, you know, as you both said, how would you decide between vendors at that point as well for a particular algorithm that you're introducing into your hospital system in terms of reimbursement? Any more thoughts?
I think, you know, I think some of the points were made earlier in terms of what's the easiest, you know, software that could be implemented within your system, depending on what the requirements are. I know for us, it's very difficult if there's a cloud-based system that we have to connect to, just because of the cybersecurity risks, I think has probably increased the oversight of IT in all of these academic institutions and sort of lock down any types of things. So I think that is one consideration. Obviously, if a company already has a product, you know, in the health system, it makes it that much easier to add on products. So I think the platform for which these AI algorithms are distributed probably will be another important consideration, especially since, you know, now that you have all these multiple softwares, it's just a lot to plug into a system. And if there is an easy platform to do this on, where you have a bunch of, I know that there are vendors who have, you know, that they, you know, are the platform, and then all these, you know, sort of have a third party of AI algorithms that can go on that. Obviously, that would make the IT infrastructure issues a lot easier.
Yeah, no, I think one thing to consider is when we think about software, how does it apply to a wide diversity of radiologists? So if you have like an MSK focused algorithm or software, well, the neuroradiologist doesn't really care about that one. They're probably not as interested. So finding something that appeals to everyone, whether it's workflow or dictations or electronic medical records, those are the softwares I think that the department are more likely to support. And also something like a marketplace software where you can select the modules within it, you can add them, subtract them as you go along. So once you have that marketplace software implemented into your clinical setting, it's a little easier to say, hey, you know, we've already done the security checks, we've already done the implementation, adding and subtracting these is not going to be the challenge anymore. So as those softwares evolve, it's not a whole new process of trying to decide if this is the right software and how to implement it. So I think those are the two things that I would look at for softwares.
I think we just got a question, an interesting question about malpractice insurance companies and our premiums, and if we would get a decreased premium for using AI. You know, I think the question about malpractice does come up, but we're just not there yet. We don't have enough data, I think, at this point to change premiums based on the usage of AI, or to say that it's malpractice to not use AI or use it.
We need a Tesla of AI to come in and say that they're going to insure physician practices based on whether or not they're utilizing their own AI algorithms.
Yeah, we do. And I mean, I think a question that comes up sometimes is some folks are worried that if the AI detects something and, let's say, saves the image with the big circle on it, you know, in the PAC system for every single study, you know, or if that's something that you only just see when you're interpreting that exam and it doesn't get saved into the system. That's a question that's come up actually from the malpractice side. Like, if you decide against the AI, then could that be a problem later on? And there's an image with the circle on it or the arrow. And I think it's just so early. We're not sure how that's going to go until it becomes a standard of care to use AI.
Yeah, I think I mean, that would be a good point. We're already, we had this discussion recently where radiologists want to add more and more imaging, and they don't want to, we're trying to minimize protocols. And I think one of the concerns with radiologists, we don't want to miss something and get sued, right? Or the wilder field, the larger field of views that you do, you don't want to miss something and get sued. So I think that's always going to be a concern when AI is implemented to go against the software, because the legal risk, it's always going to be there. I mean, it's there currently. It's probably going to take it to another level once these softwares are validated and proven. But I mean, we're far away from that to be something to be concerned about today.
I don't know if we should be, I don't know if it's so far away to be concerned about it. I think we're very far away from being concerned about the process by which we would sort of standardize that thinking. But I don't know how far we are away from somebody being sued, for using AI or for not using AI in a given situation. I think, I think we can all say for certain that's going to happen, and so we'll just have to see how. But right, we are pretty far away from a kind of some kind of a consensus that would support the whole system, right? And that's still where it's pretty wide open.
There is one question here that was kind of interesting, and it was asking whether or not is it better that the AI solution comes from the equipment supplier than coming from AI only vendor from a purchasing point of view. I don't know that at this point that's necessarily the case at all institutions, although I will say that potentially that is an option for future reimbursement, right? So that say, your CT scanner, based on CMS payments, there's an assumption of the total cost of that scanner. And in general, CMS and the RUC sort of have this inherent bias, which I think is reasonable, that over time, these costs should go down. Cost of equipment, cost of technology should go down. And the argument we always make in terms of imaging, and they say, oh, you have the PACS now, and it's much more efficient for you to read studies, so shouldn't you have time savings, and therefore there should be a decrease in valuation. Our argument is always that we're increasing the number of stuff that we're looking at, the number of images, the number of slices, the number of advanced imaging that we're looking at, that compensates for that efficiency that's being gained. And I think this may be the case potentially for equipment, right? So where CT or the PACS system eventually starts having AI algorithms on there, and there may be the assumption that over time these equipment costs should go down, but potentially as you have increasing number of AI algorithms, the cost kind of stays even. And so I know that's something that is a potential pathway for
I wonder
how it gets reimbursed.
With the software coming from the hardware companies, I do feel like that it seems appealing, and that's my experience with like a few institutions is if you have the hardware, well, we're more likely to start gravitating toward that company that's going to provide that software as well, because it seems like the integration would be more simple. You already have a relationship with them, and it's just an easy process. And that, I would say that is part of our early discussions is to work with some of those hardware providers at our institution, without mentioning all the names, but yeah, there's quite a few of them.
Well, I think you mentioned that word there is very important, and it goes back to what one of the questions that was on the table a few minutes ago was what makes you choose one over the other. And there is something to say. Well, I've actually seen some of the best AI products, right, and technologies come out of smaller startups that are pretty nimble. The question then becomes, though, to support like a large scale operation, are they practiced at relationships in the same way that Gerbet might be, that GE might, et cetera, right? All these companies that have this sort of baseline, like a ready-made toolbox to have relationships with, with complex partners like a big private practice, small private practice, academic center, et cetera. And so that's really the question, I think, is I think, or not maybe the question, but an important question, and at least for us, the way we've always made decisions is in part between, one CT scanner and another, has a lot to do with the relationship. And I think that really plays into this.
Yeah, and actually, that reminded me of one thing, because I'm big into Apple products. And like initially when I got into Apple products, it was like, oh, this hardware is amazing. And then they started working on all these softwares, and you're like, well, they make the hardware. Well, I guess the software has to be good. And once you get plugged into it, you're like, it's not necessarily you're stuck in it. I mean, in some ways it's a good thing because the hardware and software integrate pretty smoothly. But you make a good point, like maybe it's even the appeal of the name. So like you said, Gerbet, Siemens, these are big names in medicine and healthcare. So you're likely to gravitate to those companies, like those small startups that you mentioned. They might have good algorithms, good softwares, but now you're investing in something that's going to look at patient data. So you're already concerned about that, and the relationship you have with them. Are they going to be able to provide the support that you need? Those are all discussions that you have. It's like any big product that you're going to purchase. So something good points that are made.
Yeah, absolutely. I mean, that's a thought. If it comes with the scanner that you're already going to buy, like as an add-on option, then the pathway to purchase is kind of already there, right? Like it's very easy. And that brand loyalty that we're talking about with Apple products definitely extends to the hospital, as being sites of major vendors for their various scanners. In a way that they even label themselves sometimes. So that could definitely increase the appeal and maybe just make it easier from the purchasing standpoint. I think maybe we'll move on. Do any of you just closing thoughts on this, pretty broad topic, or where you think we're going or heading?
I think just in general, I mean, all good points that we made as far as looking at what vendors are more likely for institution. But just the only thing I would add to that is each institution can be different. So like what's being discussed at CHOP might not work for your institution. So you got to look what are your goals early on. Maybe it's going to be the marketplace. Maybe it's like that small company that's not well known to implement. If you have a high volume of stroke imaging, maybe that's what you should focus on. So I think it should be tailored to what you think will fit best for your practice.
Yeah, I mean, if you had to sum it up for me, it's sort of, you neither want to chase shiny objects nor dismiss them, you know what I mean? And so we I think it's at the point now where it's important to be open-minded and to be welcoming of, technology that's coming in and try to utilize it and, analyze the data, be part of gathering the data. But it's also, we all know that when the dust settles, right, there's going to be things that we thought AI was going to enable in a short term, and it's not going to be. And there's going to be things that we're surprised it can. So I think it's important to be open-minded, enthusiastic, but not get overzealous.
Yeah, I think I'm excited about the future of AI. Obviously want my workflows to be a lot easier for me to get the information I need to be able to provide the best information for all of the referring providers in a multidisciplinary way. I think that the future really is looking towards the value-based care, moving out of this hamster wheel that we're all on and just chasing the RVUs, but really looking towards how do we participate as radiologists in the value-based world and potentially developing those tools that will enable us to do maybe our work a little bit differently than what we're doing now.
Absolutely, yeah. Hopefully we can all get off that hamster wheel. Yes, that, ultimately the goal, because we definitely every single patient who comes to the hospital gets imaging. So we see every single patient that walks through the door in some capacity, and radiology is very integral to that, whether it's cancer staging or just, on-the-spot diagnosis in the ER potentially. So if it can help us do our job in an easier, more efficient way and improve patient outcomes, then I'm super excited to see where we're going with AI. And if there's any medical students on there, I still think radiology is a great field to go into because there's always something new. It's great if you want to be always learning, always developing yourself throughout your entire career. There's always new stuff. So again, we want to thank our panelists. Thank you to Dr. Goldberg, Dr. Bhatia, and Dr. Chen for joining us today, and to Gerbet, AI Med, and Applied Radiology for sponsoring us.
Yes, indeed. Thanks so much, Sonia, Melissa, Ari, Ashim, for a great discussion. And just to thanks from AI Med as well to everyone for your questions and comments too, and especially to Gerbet once again for making this 4-part series possible, as well as Applied Radiology. Again, our speakers and of course everyone in the audience. Just to let you know, this session will be available on demand at ai-med.io in the next couple of hours. So if you're anxious to watch again or you missed something, it'll be there for you to watch. For now, that's all for us today. I've been Alexis May for AI Med. goodbye, and we'll see you again soon. Thank you. Bye.